There you go. Hey, we're probably going to get started. So I have a lot of information to cover. So for those of you who don't know me, I'm Catherine McDermott. I guess I'm supposed to do this next one. How awful that is, huh? I'm quite sure. Thank you. So I am a board certified psychiatric mental health nurse practitioner. I started my career back in the 80s in nursing. First went on to become an adult nurse practitioner in primary care, and then eventually went on to do psychiatry. So I am board certified in both medicine and psychiatry. Okay, can't hear me. All right. Can you guys hear me? No? All right, I'll try to talk louder. My first love was women's health, actually. I was a certified nurse midwife for 17 years and brought in 758 babies into this world. And then I went to the other end of the spectrum in helping people with cognitive impairment and dementia. I am a co-owner here at Town Square with my husband, John. I also own a mobile psychiatric practice that goes into assisted living facilities and memory care units. And I'm also a co-owner with my husband of a medical practice that also goes into the assisted living and memory care units. We found when we got down here from the Northeast that the healthcare down here in Florida was a little bit different than we remembered. Everybody had similar experiences, maybe? Yeah. So for us, understanding dementia and understanding the people that we were taking care of, we realized that medicine played a really big role. Once we really got involved with the assisted living facilities and memory cares, we realized how many families really wanted to keep their loved ones home. And that kind of led us to Town Square, because it provides for families the abilities to keep their loved one home, but still have the respite care that they need. So that's about me. All right, so we're going to talk about understanding dementia. So the first thing we're going to talk about is the definition of dementia. And I always get very different answers from people when we talk about what dementia is. So dementia is the big, broad term that says you do not have enough cognitive ability to live independently. So what does that mean? We have independent activities of daily living, being able to shop, being able to do our laundry, being able to cook, right? Being able to pay our bills. Many people will say, well, my mom's got dementia, but she can still live on her own. Well, yeah, she's living on her own, but how much support is she actually getting? If you withdrew all of that support, could they live independently? That's the broad definition of dementia, right? Types of dementia. So we talk about dementia sort of, and we both Dr. Cummings and myself use this analogy, and many dementia specialists do, that we relay dementia to cancer. So if I said to you, I have cancer, what's your first question? What type of cancer, right? Same thing with dementia. There are 126 different subsets of dementia. There are 9 most common. And depending on your risk factors, your lifestyle, exposures that you've had throughout your life will determine what type of dementia you have, right? So if you get lung cancer, you go to the oncologist, do you go, that's great, I got lung cancer, I'll never get another kind of cancer. Is that true? No. Same thing is true with dementia. So if I have vascular dementia, because I've had a long history of high blood pressure, I might have had a stroke, multiple different reasons why I have vascular dementia, it doesn't mean that as I age, I might not develop Alzheimer's dementia. So actually the number one type of dementia is mixed, where patients will present not with just one type of dementia, but with multiple types of dementia. Does that make sense? Alzheimer's disease. So a lot of times people say to me, oh, my mother doesn't have dementia, she's got Alzheimer's. Okay. Alzheimer's is a type of dementia. Okay. So but it's a very specific type of dementia, and it can be diagnosed differently than other types of dementia. So Alzheimer's is predominantly, next to a mixed dementia, the most prevalent form of dementia. And that's why you hear oftentimes people will say, you know, I've got Alzheimer's disease. They don't necessarily correlate it to dementia, but Alzheimer's dementia is what is about 80% of the dementias that we see, or is involved in those mixed dementias where we see a vascular dementia and an Alzheimer's dementia, or Wernicke-Korsakoff's, which is an alcohol-induced dementia. And then later on, they go on to develop Alzheimer's disease. All right, let's talk about our healthcare system. So if we have to really look at understanding the prevalence of this disease, and I think this is highly, highly underestimated, right? That 1 in 6 seniors, so people over the age of 65, that's our senior group, right? So 1 in 6 are living with dementia. By the time you hit 90, 50% of people have some form of cognitive impairment, if not full-on dementia. Okay? You can't hear. Can you come sit closer to the front then, perhaps? Yeah, let me see if I can get them to get me a microphone. Hang on, guys. No, this is recording. Yep, come on up. Melissa, I need a microphone. They can't hear me. I need the mic. Okay. All right. All right. She's going to work on getting that. In the meantime, I'm going to keep going here. Unfortunately, it's very noisy out there, and I think that's what's making it worse for you folks. All right. So 1 in 6 is living with dementia. And again, like I said, I think that's highly, highly under what we really see out there. Resources and education. And that's one of the big issues that brought John and I to begin to think about opening a town square and to trying to get the word out there. I have never in my medical career, nursing career, ever seen a disease that is so prevalent that has so few resources. Would you agree? I mean, you go to the oncologist and you get a diagnosis of cancer, you have a whole team of people that are taking care of you. You have a surgeon, you have an oncologist, your primary care gets involved. You get a diagnosis of dementia and you get, see you in 6 months. You've just been diagnosed with a terminal neurologic disorder, and you get sent out the door with literally nothing. Next steps for families. So we're going to talk about that throughout this in terms of diagnosis, what's out there in terms of treatments versus medications to just help with dementia. So we're going to get to that. And again, if this was cancer, right, it would be treated very, very differently. All right, so let's talk about the pathophysiology of dementia. So what puts you at risk for dementia? Anybody? Age. Age is the #1 risk factor for dementia. What else? Heredity. That's correct. So if you have the APOE gene, you have a 30% chance of developing dementia. That's right. Our diet. Our diet. Inflammation. Thank you, sir. Can you hear me? Hello? I don't think it says it's on, but now it's not doing anything. Hello, hello. No? Hello? 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 How's that? Is that better? All right, we're good. We're good to go. All right, 10 minutes in, we fixed it. All right, good. All right, so age, our diet, one of the big things that we're learning now is inflammation. It's the big thing, right? Everybody's talking about GLP-1 treatments because of the decrease in inflammation and the benefit that it can have for people with inflammation in their brain and potentially developing dementia. So certainly our diet is very important. What else? Let's talk about lifestyle. What in our lifestyle puts us at risk for dementia? Sedentary lifestyle, very important. If we don't keep that blood flowing to our brain, very important. The other thing is socialization. And this is where Town Square, again, comes in very important for these folks, is that if you don't make eye contact with somebody and have a conversation and eat across the table and engage with people, you will lose your cognition. It is a known fact. During COVID, we saw people rapidly decline cognitively because they didn't have that socialization that we crave just as human beings. What else? Genetics, risk factor, environmental. Anybody else think of anything else environmentally? We have a lot of vets here at Town Square. Toxins, yep, Agent Orange, mercury, things that are in the water, things that all of those things will affect brain health. Okay?
Hearing loss.
Hearing loss, correct. Hearing loss will accelerate it, typically, doesn't always cause it. Say any of our senses that are diminished, our hearing, our vision, all of that will further the disease process. Head injuries. Very good, head injuries. Why head injuries, do you think? Yeah, why? Anybody know why?
That's what the brain is.
Trauma to the brain, correct. And the brain is enclosed in the skull, which doesn't have any space to open. And so people fall and they get what we call a subdural hematoma, which is bleeding under the brain. And the neurosurgeons don't want to take you to the operating room when you have a mild to moderate brain bleed, because typically it will resolve on its own. What happens is, while it's resolving, it's like stepping on the grass. And so that little spot of grass, that was where that brain bleed was, doesn't ever come back. And the patient develops something called encephalomalacias, which are literally holes in their brain. And you can see it on CAT scan and MRI. And people will say, well, I didn't know I had a brain bleed, because many times people fall and hit their head. How many times do they always go to the ER? But they can have a small brain bleed that then later on has caused one of these encephalomalacias in their brain. All right. All right, this is always a big one for me, because people come to me and they're like, well, I was never diagnosed, or I was diagnosed 6 months ago. When you are diagnosed means nothing. That just means when you got yourself in to see the primary care, who finally said there was something wrong, who sent you on to see your neurologist, and you began the workup. Most often, people that come in for testing and start to see differences are in stage 4 or stage 5 of the disease. There are 7 stages to dementia. And I'm going to go through those real quick here, just so it'll make sense to you in terms of this, okay? So stage 1 is actually normal aging, right? I put my keys down, I can't remember where they are, I get a little frustrated, technology's a little harder for me. That's normal. That's not dementia. You're still functioning independently. That's normal aging. Stage 2 is where you yourself start to notice things. I can't remember the last 4 digits of my phone number. That's odd. I think back to something that I used to do, and I used to be able to do it quite easily. Now I can't bring it forward. I have difficulty sequencing or performing things that require a lot of executive function, which is multitasking and be able to follow steps in an appropriate manner, right? I mean, think about how much executive function you need to work a computer. You hit the wrong button in the wrong order, you're at a completely different screen doing something that's not what you wanted to do, right? Stage 3 is when other people start to notice that you're having problems. So stage 3 is when you're, especially for my working 60-year-olds and 70-year-olds, all of a sudden, they're not making the grade anymore. The boss is calling them in, they get a bad review, and they've always been an exemplary employee. This is when stage 3 really begins to become apparent. They really start to struggle. They come to you and they say, dear, I've always paid the bills. I think it's your turn to take over the bills. Really? Is it because I can't do the bills anymore? And I don't want to admit to you that I can't do the bills anymore? But a lot of times, that's what it is. You're struggling with things that you used to be able to do, and you are at that stage where you're beginning to need support. Stage 4 is when the diagnosis occurs. Stage 4 is where you go to Publix and you get lost. You go to Publix to get 2 things and you get there and you can't remember what you were there for. You come home and there's 12 dozen eggs in the refrigerator because every time you go to Publix, you buy a dozen eggs because you can't remember what's in the refrigerator, right? This is where it begins to become a problem. You stop taking your medicine. I want you all to think about how difficult it is to get a prescription filled, right? You have to go see your provider because they're not going to write a prescription if you just call and say, hey, I need this, right? Then they have to send you to the pharmacy. Then you got to go to the pharmacy and get it. And then the pharmacy says, oh, we didn't get that prescription. Then you got to call the physician's office back, right? How many of this is how you have this happen to you, right? You finally get the prescription, and then now you have to take it the way you're supposed to take it. People in stage 4 dementia, they can't even get to the point that they know they need to go to the pharmacy to get the medication. They need significant supports. They need somebody else to help them in order to do these activities of daily living. Stage 5. Most of our members here at Town Square are stage 5. These are the folks that are really now beginning to need assistance with their, not their independent activities of daily living, but their activities of daily living like dressing, bathing, going to the bathroom, showering. Dr. Cummings and I all love to talk about showers. How many steps does it take to take a shower? Anybody? 43. Let's just wash our hair. We have to wet our hair. Now we have to find the shampoo. We have to pick it up. We have to open it. We have to put some in our hand. We have to lather our hands. Then we have to lather our head. Now we have to rinse. We've done 6 steps, and all we've done is wash our hair. You don't think about it that way, do you? So when you hand your husband, your mom, your wife the towel and say, go in the bathroom and take a shower, and they go in and they turn the water on, they come back out, it's because they don't know what to do. They don't know how to initiate anymore. That's stage 5. They need a lot of prompting and cueing because they can't do these things on their own. Stage 6 is when they really start to look sick. Stage 6 is where their face is more drawn. They have that absent look in their eyes. They can't, their body can't tell them that they need to go to the bathroom. They'll look at their food. They're hungry. They don't know how to pick up the fork and even begin to feed themselves. Stage 6. Stage 7, most people with dementia don't live to stage 7. It's very rare. I think in my whole career, I've probably only seen a dozen people actually get to stage 7 because by the time you get that far into the disease, something else has likely happened. You've had another heart attack, you've had a stroke, you've had a fall that caused a broken hip or a subdural hematoma, something else has taken you. But if you do manage to get to stage 7 is where, you know, your brain can't tell your eyes to blink or your lungs to breathe. And a lot of times I'll have patients that family members will say, well, he's healthy except for his dementia. The analogy I use for that is that's like saying I have a beautiful house that is completely done and every room is gorgeous, but the roof leaks. Our brain is what does everything for us. So if your brain is not healthy, you are not healthy. You may not have other medical, what we call comorbidities, high blood pressure, hypertension, diabetes. But when you get to stage 4 or 5 of dementia, you're not healthy. Your brain is damaged and it's resorbing and it's not working. The average, we say, is between 12 to 15, oops, where was it? 12 to 15 years people will live with dementia. What did I do? Okay. 12 to 15 years, people will live with dementia. Stage 7, it's really when we, you know, is from 5 to 7, we say 2 to 3 years when people get into that range. All right, so let's go back to how do we diagnose it. So clinical assessment, history taking. This is so important. So important. Yeah, how am I going to know that you have Wernicke-Korsakoff's, which is an alcohol-induced dementia, if I don't ask you those questions, right? How do I know what your risk of Alzheimer's is if I don't find out what your family history is? How do I know if you might have a chemical-induced dementia because you were exposed to Agent Orange when you were in Vietnam? So the history taking is incredibly important. And it's one of the things, because we live in a society where clinicians get paid for seeing more patients in an hour, right, than doing a thorough job, a lot of times the health history doesn't get taken the way it should. Because a lot of the history is very important. One of the common disorders that is oftentimes mistaken for dementia is depression in the elderly. If you're depressed and you're apathetic about life, and somebody gives you a memory test and you barely engage, you're going to score really low. Well, if we treat your depression, maybe you don't look so demented. Maybe your depression just needed to be treated. There are many other comorbidities that need to be looked at. So the physical examination is very important. The next thing that I see, and I was just talking to Dr. Cummings about it, who's speaking later on, she had a woman who emailed her that her husband had microvascular changes on his CAT scan, and she wanted to know, does this mean he has vascular dementia? Well, a lot of us have microvascular changes on our CAT scan. It's very common over 65, but you have to correlate it with the neurocognitive testing. So if I was a highly accomplished, high IQ person living in society and I start to decline cognitively, I develop what we call compensatory strategies. I figure out how to hide from everyone, sort of including myself, that I can't remember how to do a lot of these things, right? And when I'm able to do that, oftentimes people don't realize where I land in my level of dementia, right? So the neurocognitive testing is very important because it looks at all the different domains that memory and cognition include. So cognition is just not short-term and long-term memory. It's how we process information, both visually, both auditorily. It looks at executive function, how we can carry out multiple steps, right? As well as short-term and long-term memory. So having the neurocognitive testing is really important to us as clinicians because it gives us a lot of information. Does that make sense? I would say in my practice that I get maybe 5% of the patients that come in who tell me they've actually had neurocognitive testing. Most of them have gotten to stage 4 or 5, had a CAT scan that shows some sort of decline, whether it's vascular, whether it's white matter resorption, whatever it is. And they've had a cursory evaluation by their primary care that puts them in a mental status exam, a SLUMS, a MOCA, any one of the markers off of 30, and we kind of give you a basic range. We do that here at Town Square too for many of our families. And they get what's called a presumptive diagnosis of dementia. I am. That's next, right there. Okay, so imaging techniques. So we have CAT scan, we have MRI, and now we have amyloid PET scan. So amyloid PET scan is only helpful if you have Alzheimer's dementia caused by amyloid plaques. So if you have a CAT scan and the CAT scan shows that there are an amyloid, that you have no amyloid plaques, that doesn't mean you don't have dementia. It means you don't have Alzheimer's dementia because the amyloid PET scan is only looking for amyloid plaques. Okay, does that make sense? So neurocognitive testing is done by a neuropsychologist. Okay, they're not medical doctors, they're psychologists, and they specialize in this particular testing. Neuropsychiatric testing is a 4-hour test. So you go, they make sure you've had a good breakfast, you ate your Wheaties in the morning, you got a good night's sleep, you're well hydrated, because they're going to put you through the ringer for 4 hours. And then they're going to tell you to leave. And they'll have you come back in 2 weeks after they analyze everything. If they're good neuropsychologists, they're going to get your medical records. They're going to get your imaging. When you leave the neuropsychologist, you should know what type of dementia you have and what stage you're at. And if there is other comorbid factors, like do you have depression? Do you have generalized anxiety disorder? Is there some other factor that might be contributing to your decline cognitively? Okay. All right. All right. So here at Town Square, and our focus is to do what we call person-centered care. So what does that mean? What does person-centered care mean? So you come to me and you bring me your neurocognitive testing, and it tells me that you're not an auditory processor. If I cue you with verbal prompts, is that going to be helpful for you? No. You're the person, I have to put the big sign up that says, Mom, remember to close the refrigerator door, right? Or lock the door before you go to bed. Now, if Mom's not a visual processor, how are those prompts going to help? Right. So understanding where that person comes from, where their deficits are, helps us to develop what we call person-centered care approach. All right. Communication strategies. So, and a lot of this that we're talking about are now with folks that are in stage 4 and stage 5, right? So when we talk about verbal and nonverbal communication, again, the verbal communication is we want to obviously tell our person with impairment how to do something, how to cue them to do something. But nonverbal is very important. And this is something that I teach all of my staff here at Town Square. We smile. We make eye contact. We wait. We say to one of our members, come on, Ron, let's stand up. And we show Ron what we want him to do. We look at him right in his eyes and we smile and we step back. Do you know how long it takes for somebody with stage 4 or 5 dementia to process a verbal command? 15 seconds. That's an eternity. And when you give them the next command and they're still processing the first command, it becomes a highway backup. And now they don't know what to do. And they sit there and they look at you with that look like, I'm not really sure what to do. We want to give them that moment. We want to give them that time. And my staff is always shocked. We can't get somebody to do something, come out, we go over this again. And we sit there and they think, he's not going to stand up. He's not going to stand up. And then all of a sudden, stands up. All of a sudden, it hit bottom. But we're so used to saying, come on, we're going to go to the diner. Come on, we're going to the diner. Come on, it's time to go to the diner. 15 seconds. It's a lot. So verbal and nonverbal